So the basic question of what sarcoid is has occupied thoughts for at least half a century, but we can say it is a form of loss of balance of the immune system in which certain inflammatory cells aggregate in tissues and they cause the consequences we all know about: scarring, symptoms, damage to organs, or in some cases minor inflammation that goes away. So it is essentially that, a loss of balance of the immune system. To what extent this is driven by hidden triggers that set it off, and to what extent it is a form of autoimmune illness, is debated. What we do believe is that illnesses do always have causes, but the problem is we can't see those causes very clearly in sarcoidosis. And then the question is, what causes sarcoidosis? And the very words give us an assumption which we have to question, that there is a single cause. By now, if there was a single cause, we would know it. People have spent research careers trying to find one. And sarcoidosis has been studied enough that associations would give us a single cause. The problem in sarcoidosis is that we have half-convincing data suggesting that in different people there are a number of different causes for this. So what sends the immune system off balance is really the question. And what sends the immune system off balance, for a start, is likely to be different in different people, depending upon their basic makeup. So you can say that perhaps all of us have a pathway to getting sarcoid with our personal makeups if we're unlucky enough to run into something with our name written on it. And so you begin to believe, based on incomplete data, that there may be 20 different triggers in 100 different people. Certain things stand out, so it is very likely that there is a group of people with sarcoidosis who get the illness triggered by certain bacterial infections. Perhaps fungal infection can do it in others. There's a school of thought that mycobacterial antigen, in other words, if you like, some of the makeup of tuberculosis, some of the makeup of what we call atypical mycobacterial infection, which is like tuberculosis but not infective and transmitted. People believe maybe some of that material can set sarcoidosis off. And I could spend the next 20 minutes talking about 15 different triggers, but I'm not going to do that. Enough to say that I don't think we will find that knowing the trigger actually helps, because once sarcoid is set off by whatever triggers it, the problem then tends to persist. And I suspect that in most people, by the time they're found to have sarcoidosis, that which sets it off has probably gone away. How is sarcoidosis diagnosed? Well, firstly, you find a fairly large group of people who have what might be called classical sarcoidosis. That is to say, they have the typical symptoms you first get, very often a classical chest X-ray appearance. And so for some people, you just know that what they have is sarcoidosis. And even the most fervent investigators who might be inclined to biopsy very liberally will accept that there's a group of people where you really don't have an alternative diagnosis. And we can guess what proportion they make up. I suspect it's a fairly healthy proportion, where you are able to make the diagnosis without proceeding to additional tests for diagnosis. Then you have a group of people where sarcoidosis is quite likely, and you've got to make some core decisions as to how far you will go with treatment. And how far you will go with treatment will influence how important it is to be exact about the diagnosis. So you have to make a judgment. What additional tests are you going to do? If the problem is in the lungs and there's doubt about the diagnosis, you may very well find that performing a CT scan and full lung function tests carry you to a point where you have no real doubt. So now the proportion of people you can diagnose without proceeding to a biopsy is starting to rise. And then you will have those people where the diagnosis is actually quite likely but not certain. So let's imagine that we're saying these days around the world, if you're 95% likely to have a disorder, that's what you call a diagnosis. There's hardly ever 100%. But you're saying you're making a diagnosis at that level, and you accept you don't need necessarily to go to perform biopsies at that point. Now, what if you're 85 or 90% likely? And that's where the patient has to be empowered, because the patient should be allowed to make a judgment, either that they might follow a recommendation to have a biopsy to get up to certainty, or the diagnosis is very likely and they should be allowed to choose against having an invasive procedure on the understanding you're going to focus on the behavior of the illness, and you're going to accept that a diagnosis is very likely but not certain. So if you are going to go to a biopsy, most commonly you're talking about either a biopsy of lung tissue, and more recently, more commonly, an ultrasounded needle sampling through a bronchoscope of some of the lymph nodes adjacent to the airways. So that's what you're generally doing. But I do have to say that patients do want to exercise choice on this. And I think we must support those patients who feel that they will accept a 90%, we can't be that exact, but a not quite certain diagnosis, on the understanding you're going to come back and think about the diagnosis again. Now look, sometimes you have to say to somebody, there's a diagnostic possibility that isn't sarcoid that is worrying enough that you have to go the extra mile to know what's going on. Now, a lot of the time that isn't true, but sometimes it is. So sometimes sarcoidosis can overlap in its behavior with a lymphoma, for example. And you would then be compelled to urge the patient to undergo a biopsy procedure to sort that out. Sometimes tuberculosis can be very similar to sarcoidosis, and to confuse matters, sometimes the clinical pictures and the imaging in certain contexts can be similar. And once again, you want to go the extra mile with investigations to sort that out. That wouldn't necessarily require a biopsy. So I think, to summarize, we've got patients who can be diagnosed on classical grounds without a lot of tests. We've got patients who are not quite there on how they appear with their illness, and you have to go a bit further with tests, but you don't have to go to a biopsy. You have patients where you should have a discussion empowering patients in their choice as to whether you're going to take the final step to a biopsy. And then you have patients where you have a duty to persuade them to have a biopsy. 4 groups. Okay, now we've come to the largest question of all, which is the treatment of sarcoidosis. And can I just say this is confused? And it shouldn't be confused, because there is a clear pathway through. So historically, people wanted a one-size-fits-all approach to treating sarcoid. Human beings don't like uncertainty. Doctors don't like it. Patients don't like it. People would like a menu. They would like guidelines. They would like a formula. And for many illnesses, to a certain extent, although never completely, that broad approach is helpful. In sarcoidosis, this led over the years to some extraordinary distortions. So there have been units that treat every patient with sarcoidosis. There have been units that treat virtually no patients with sarcoidosis because we don't have definitive trials, and I suggest there hasn't been enough flexibility of thought. And neither approach is appropriate. But the most common approach is still a protocolized approach. If you choose to treat, where you start with very often punitive doses of steroid for the first 3 to 6 months, and an awful lot of steroid burden down the years. Now, there's been a sea change, I think, in the approach and thinking behind sarcoid treatment, and the guidelines currently being developed with the European Respiratory Society are based on what I'm about to tell you, which will also appear before too long as a WASOG position statement on treatment in our premier respiratory journal. So you have to stand back and say, what are the reasons to treat sarcoidosis? If you're not going to accept that everybody with sarcoidosis must have steroid side effects and you're going to be selective, what are your reasons to treat? Now, if you go to the internet, you read medical textbooks, you will find these overpowering long lists of reasons to treat sarcoidosis, sometimes 20 or 30 different reasons, and that's confused. We don't have 20 or 30 different logics in order to use therapy. So we do, in fact, have 2. We have that sarcoid is dangerous in an individual, and by that I mean they've got a type of sarcoid where there is a risk of losing life expectancy or having major disability from organ damage. And without a doubt, somebody who knows that will usually want to receive medical expertise and reduce or remove such a risk. Then the second reason, which is disconnected, to be colloquial, the patient with sarcoid is simply feeling rotten. They may not have danger, but they have an unacceptable loss of quality of life. So with any condition, patients receiving treatment will want either to live longer, feel better, or both. So we have to turn around on sarcoid and devise our reasoning such that treatment is either directed to the first goal, the second goal, or both. And if you can't tick either, you should not be throwing therapy at patients with sarcoidosis. Nor should you have a confused half reason from danger and a confused half reason from quality of life. That doesn't add up to a logic to treat, it adds up to confusion. Now, patients are not foolish about such matters. If they have unacceptable loss of quality of life, and that's the reason for treatment, and somebody piles in with high doses of steroids and the patient feels worse, that's a failure of therapy and the lack of a shared logic in why treat. So I think that you have 2 different treatment regimens. One of them applies to dangerous disease, and it's your job as a doctor to define that. And you're going to tell the patient the first time you meet them, look, it's my job to do that. I'm going to look for hidden danger, and it may be unfortunate, I may just have to be twisting your arm for therapy, but naturally I hope not. So you're disempowering yourself at that point as much as you can, and you say, look, the other thing is, if there's no danger, we have to think together about whether the impact of what you have is upsetting your life so much that we can look at a low-dose approach without the side effects and see if we can transform your life. So just dealing with those 2 things, you would say, looking at statements around the world made using a number of different methods, different populations, probably about 7% of patients with sarcoid have loss of life expectancy due to sarcoidosis. Now, that happens in people with major organ involvement, which we think is about 30%. So we're talking about 7 over 30, 20 to 25% of people with sarcoid, with clinically major lung involvement or heart involvement or central nervous system involvement, will lose some life expectancy from sarcoid. And if you can see that risk quickly and treat earlier, you have a very good chance of reducing that risk. So you are looking at risk stratification at the outset. And patients understand risk-benefit. I think it's a common misconception that this is all too much information for patients. That's dead wrong. Any patient who has time to think will understand risk-benefit thinking. And so it's your job to lay out the risk and then to provide the medical expertise, and you will often have to go to high-dose treatments in that setting. And you have to accept there may be side effects and have a discussion where you're pointing out that against this, there may be hugely beneficial consequences. Now, if you overdo that, you will have some patients dying from the diseases associated with too much treatment. So you've got to be very careful in that regard. Steroid therapy and its associations with diabetes, high blood pressure, you've got to balance that against very real risks which are higher in somebody with dangerous sarcoidosis. And we're not talking about 7% because you're looking to risk stratify, and you might be talking about more like, and I'm having to guess a bit, 15 to 20% of people with sarcoid starting in what seems to be a higher risk group. But what you're hoping is that very often good early responses mean somebody moves out of that group and you're bringing the therapy down quickly. Now, I'm dealing with this first because this has underpinned the various approaches taken around the world. There's been this approach, as I said before, megadose steroid, punitive doses, side effects that really in some cases turned out to be completely unnecessary. But I would say the more frequent problem is people feeling unwell but not in danger. And so I'm going to move now to this second point because this is where patient empowerment is absolutely crucial. So a doctor can't come in and take a know-all approach to the impact of sarcoidosis on somebody's life. And the impact is a package. There's no point in taking just cough, just tiredness, just joint aches and trying to make state-of-the-art comments on how you manage these in isolation. The patient will have a package of feeling unwell, which will be unique to that patient. And what you need to agree on, and this is the bit that probably isn't negotiable, is the patient taking a view of the impact of these symptoms on their lives. And often you have to give them time and space to think about that. You can't do that in the first interview and just extract this information. And I think one of the points of this is to establish that you're in a partnership on this treatment from day one. So you'll meet somebody, you'll tell them that you're going to exclude and endanger, that the tests might take another month to complete, and could they take the next month, thinking about this every day, just to think about the impact of sarcoid on their lives, and come back to a conversation where you're going to talk about that. So for fatigue, I can't do a blood test that tells me that a patient has 17.312 units of tiredness. So I can't be all scientific about this, and I'm critically dependent on what the patient feels they need to be sensible about what we might do. And then at that point, for quality of life, I feel strongly that you must make 20 different deals with 50 different patients. You've got to think about their worries about steroid therapy. And very often they've had a family member who's been given high-dose steroids and they're terrified of that approach. You've got to think about their priorities. Some people will decide that they've got difficult symptoms, but on balance they would rather leave them alone. And if there's no danger, who is to say that that is incorrect? I do sometimes feel people need to try very briefly some steroid therapy just to get a sense of what might be achieved, because that is information. The informed patient knows what benefit might exist, and until you actually try some treatment for feeling unwell, you never in any one person know that with certainty. So you're just feeling your way, but above all you're empowering the patient because you're in there together. And if the patient understands this and understands that the chance of a benefit is higher than the chance of side effects being a problem, they'll also understand that either could happen, you're in it together, and it doesn't come across as a failure of treatment if they're unlucky with a particular treatment. Because you've understood this, you've signed up to a shared approach, but I think it works best if the patient calls the shots on quality of life. Now, there's only one additional point to make about that. I'm old and ugly enough that people will know I'm not sitting on the fence. If you're a younger doctor, I think the risks are that a patient will think that you're frightened to make a decision. So this is a different model to normal medical practice. It's a required model, in my view, for sarcoid. But as a doctor, you probably need to say, look, if you want me to be God and make decisions, and you require me to do that, of course I'll make them, and I would take a view. But I think the decision will be a better one if you are able to take a view. And so I think you probably have to make that clear if you're then going to work along those lines. So that's in a nutshell treatment. We've got two diseases with two treatments. And sometimes, of course, you have danger and loss of quality of life, but the treatments you use for danger, which are higher, will actually give you what you can get for quality of life. But I would say more commonly, you're actually moving away from these punitive historical regimens and finding a civilized balance, with the patient actually being an absolutely key driver in that regard. So I'm sorry about the very long answer, but it's something that is being transformed right now in our field. And you have advanced knowledge here of the ethos behind the guidelines. It's certainly a personal philosophy I've driven over the years, and so I'm thrilled to see this coming to fruition at present.